The glenohumeral joint has a very large bore with a relatively shallow socket, and as a result, the shoulder is the most mobile joint in the body. However, to achieve this, it's heavily reliant on the various soft tissues for stability and movement, including the capsule, ligament and tendons, and also the surrounding muscles. As a result, there's a myriad of problems that could go wrong with the shoulder. However, for about 90% of patients, a differential diagnosis can be generally measured by their age. In patients under 25 years of age, instability, either atraumatic or traumatic, is really the main cause of problems. If they do have rotator cuff problems, these tend to be due to a secondary tendinitis due to the instability, and if you treat the instability, the rotator cuff problem will settle. In patients from 25 to 60, rotator cuff problems, including the long-headed biceps, are by far and away the most common. However, frozen shoulder is also quite prevalent. AC joint osteoarthritis, glenohumeral joint osteoarthritis, and instability still do occur. Over 60, frozen shoulders rarely occur, and the most common pathology again is rotator cuff disease. Glenohumeral joint OA is far more common, and rotator cuff arthropathy, which is a form of arthritis due to a massive rotator cuff tear, is also present. The management of the vast majority of these conditions can generally be done between the GP and the physiotherapist. However, on occasion, they do need to be referred to see an orthopaedic surgeon. This is what tends to happen in the independent sector in the UK. However, in the NHS, there's an MSK pathway, which really is suboptimal. A GP can only refer a potential problem to the physio, and the patient has to have had 6 months of physiotherapy before they can be referred to an orthopaedic surgeon. In patients under the age of 25, instability is the main problem. This can either be traumatic due to an injury in an otherwise normal shoulder, or atraumatic. Previously, this was thought just to be due to joint laxity, but there is a second type of atraumatic instability known as muscle patterning or muscle sequencing. This is where the various muscles that stabilise the shoulder work out of sequence. It's difficult to truly describe this, but it's best seen by this little video of a patient with muscle sequencing problems, and as you can see, as they're lifting their arm up, the shoulder's popping in and out. It's being actually pulled in and out by various muscles firing in the wrong way. Muscle patterning is generally treated with physiotherapy, and this is the same patient a couple of weeks later after they've had adequate physiotherapy. You can see that their glenohumeral function has now returned to normal. Patients can actually have varying types of instability within the same shoulder, and the Stanmore triangle describes this, with polar type 1 being traumatic, polar type 2 is muscle patterning or non-structural, and polar 3 is atraumatic and structural. For traumatic instability, the diagnosis is often made from the history of a traumatic event, and on examination they have instability signs. Generally, these patients are going to require some form of surgery to stabilise their shoulder and should be referred to an orthopaedic surgeon, where an MR arthrogram will diagnose the actual pathology, and then the type of surgery can be decided. For atraumatic patients, they often have no specific history of an injury, and when on examination, they often have generalised laxity and instability in a number of directions. These patients are generally best managed by physiotherapists and should be referred by their GP to the physio, and they will undergo a rehabilitation program. Very occasionally, if they fail to improve, they may be referred back to the orthopaedic surgeons for MRI scan, because sometimes they can also have a structural problem. For patients over 25, as a general rule, atraumatic instability does not occur. So between 25 to 60, it's generally traumatic, so once again they give history of a traumatic event, and they are likely to continue to dislocate and should again be referred to the orthopaedic surgeon for MR assessment and surgery. Over 60, if patients have a traumatic dislocation, they often end up sustaining a massive rotator cuff tear, which is far more troublesome than the actual instability itself. These patients should have MRI scan to assess the rotator cuff, and their treatment may either be rehabilitation or surgery. For patients as they get older, the general consensus for treatment is to treat people by their physiological rather than their chronological age. One of the reasons I prefer to use MRI scans is they can give me a good indication of muscles and age and help me to see how I'm going to choose to treat a particular patient. However, the structural or MRI pathology doesn't always correlate with the clinical symptoms. So there are patients who've got asymptomatic cuff tears, and there are other patients who've only got a mild tendinitis but seem to be very disabled. The initial treatment should always be based on the clinical symptoms. These symptoms tend to include pain, weakness, and to a greater or less extent, loss of movement. The mainstay of treatment is orthotherapy. This involves initially controlling the pain, and this can be done with simple non-steroidals or occasionally a subacromial cortisone injection, which can either be administered by the GP or the orthopaedic surgeon. Following this, it's over to the physiotherapist, where the patients regain their range of motion and then can work on a muscle strengthening program. Referral to a shoulder surgeon is based on failure of improvement despite adequate orthotherapy. However, there's one group that should perhaps be sent to the orthopaedic surgeon more quickly, and this is patients that have had an obvious acute injury or cuff tear. So this person who had a completely normal shoulder has an instant where they feel it tear, and following that they've lost a lot of motor function, particularly supraspinatus. These patients who've got an acute or acute on chronic tear tend to do best if they get surgery within 3 months of their injury. My investigation of choice for rotator cuff disease is always an MRI scan. This helps me to not just see the tear but also give me an indication of any muscle wasting, which can give me an indicator as to how best to treat that patient. Another common condition affecting patients between the ages of 25 and 60 is frozen shoulder. This has been described as an enigma. It tends to have an insidious onset, although it can be precipitated by a preceding injury. It's often difficult to differentiate from cuff disease in its early stages, but patients who have constant pain and loss of movement are more likely to be developing a frozen shoulder. It tends to affect females more than males between the ages of about 40 to 60. The underlying pathology is due to a capsulitis. This is often very difficult to diagnose by any imaging. The only time you can really see it is on an MRI scan where patients may have some form of pericapsular edema. A frozen shoulder tends to proceed along 3 symptom-related phases, which tend to be self-limiting. It is more common in patients who have insulin-dependent diabetes and tends to be more aggressive, and we found that people who've had the COVID vaccination are getting more episodes of this, although we don't know why. There tends to be 3 forms of timeline for frozen shoulder. There's a mild form that probably only lasts 6 months, and a lot of the time patients don't get to see the physio or the doctor until they're actually improving. However, there are more severe versions that can last between 12 months and over 2 years. The empirical treatment of a frozen shoulder is tailored to the phase. So in patients who are in the freezing stage, analgesia and symptomatic relief is the best. Physiotherapy should really be reserved for the thawing phase. It's important not to force the shoulder to keep moving in the freezing or frozen stages, and there are no medals for bravery. Hydrodistension is a relatively new treatment that has really transformed the management of frozen shoulder. It can actually be done at any stage of the condition. It involves injecting normal saline and cortisone into the shoulder. The normal saline is injected under pressure, and the thoughts are that it distracts and breaks down the adhesions. Patients tend to get a rapid pain relief with a variable initial recovery of range, which tends to improve over time. About 80% of patients get a benefit from their first hydrodistension, and of the 20% that don't get that benefit, if they have a second, 80% of them get better. Referral of hydrodistension is based on established frozen shoulder diagnosis, which may require an MRI scan. For patients who have a refractory frozen shoulder, an arthroscopic capsular release is the treatment of choice. This is only for very resistant cases, but it does have extremely good results. Osteoarthritis presents with pain and stiffness and can generally be easily diagnosed with a plain X-ray. Patients who had previous trauma or previous shoulder surgery have a predisposition to developing osteoarthritis at a younger age. The treatment of osteoarthritis is based on managing the symptoms. In the early stages, physiotherapy and anti-inflammatories can give good relief. A cortisone injection or hyaluronic acid injection can give good temporary relief, and patients with earlier osteoarthritis can benefit from an arthroscopic CAM procedure. However, patients that have failed these and have got more advanced changes will always benefit from a joint replacement. In the early stages of osteoarthritis, management can be done between the GP and physiotherapists, but once it gets more severe, referral to an orthopaedic surgeon is most appropriate. For patients with end-stage osteoarthritis, the trend has been towards total shoulder replacement. For patients who have got minimal bone loss and good rotator cuff quality, a short stem replacement with a ceramic head is now the treatment of choice. Patients can expect to be pain-free after their surgery and probably regain 70% of their function. There's very little restriction on their activities apart from contact sports. We've covered the commonest 90% of shoulder conditions. However, the shoulder girdle is made up of not only the glenohumeral joint, but also the acromioclavicular joint, the sternoclavicular joint, and the scapulothoracic joint, and the pec major and lat dorso muscles, and the long-headed biceps and triceps muscles. All of these can potentially lead to some form of pathology. If you'd like to know more about any shoulder condition, and particularly the more exotic versions, my website, Cambridge Shoulder, covers the majority of these. As you can see, it has a drop-down folder, and in that, for example, for the rotator cuff, it will cover the actual pathology behind it, how we diagnose and examine the patient, and then the various treatments. It also goes through the various types of surgeries and the expected recovery.